Okay. These are my disclosures. And I want to begin by noting that the term smoldering myeloma was adapted from the term smoldering leukemia, which was quite popular in the 70s. And as you can see in this graph describing the number of Google hits identified per 5-year period, the notion of smoldering myeloma being an important topic has accelerated in the past decade. When we go back and examine the seminal articles, we identify several very, very important publications from over 30 years ago. The first is from Dr. Kyle, who coined the term in a New England Journal article. And what he said, quite simply, was that he'd been following 6 patients for over 5 years. There'd been no progression to organ damage, and in patients who had myeloma based on bone marrow and M protein, but no evidence of organ damage, they should be followed and not treated. And he notes therapy may lead to leukopenia, obviously with melphalanoprednisone in mind, and unnecessary chemotherapy causes unnecessary expense, and it is a source of concern to the patient. We have similar concerns. Our patients have similar concerns in the modern era when we have quite effective new agents that are certainly less toxic in many instances than, for example, high-dose dexamethasone, and are also quite expensive. So as we move forward implementing novel therapies for patients with high-risk smoldering myeloma, we also have to take cost into account. The other very clear voice in this area was Dr. Alexanian. And in his Blood paper of 1980, he described a large cohort for that time of patients with asymptomatic myeloma and made a series of very important observations. First of all, he said, some of these patients, even though they're asymptomatic, have higher tumor burdens and should be treated. So he forwarded the concept of preemptive therapy if the tumor burden were high. He also noted that serial assessments of the myeloma protein were useful. So he forwarded the concept of following trends, as particularly of M protein and light chain levels in the urine, as a way to identify clonal proliferation. Subsequently, he published a manuscript with Dr. Demopoulos in 2000, in which he described patients who had smoldering myeloma stratified based on 3 variables. One was urinary Bence-Jones protein greater than 50 milligrams a day. The second was M protein greater than or equal to 3 grams per deciliter, and the third was IgA isotype. If you had any 2 of these 3 variables, you had high-risk smoldering disease. If you had none, you had a low-risk disease, and if you had one of the 3, you were intermediate. In that same manuscript, he described a way to assess those at intermediate risk using spinal MRIs. And this approach to smoldering disease had become quite the standard of care, and in many instances, and in many Western countries, remains a standard of care to this day. Dr. Alexanian also commented on a pattern of accelerated M protein increase, stating that there appeared to be 2 patterns as patients evolved to myeloma. One pattern was a gradual increase shown on the right hand frame, and the other pattern was what appeared to be a gradual increase followed by a dramatic spike in the M protein, suggesting rapid clonal proliferation. These graphs are actually the work of Brendan Weiss, who has published on this, confirming Dr. Alexanian's observation of 32 years ago. So as we look back on this whole field, we have traditional and modern elements. The traditional elements are listed here, including time, that is to say tracking trends, and traditional clinical philosophies. Any of you who are at ASH in the 1990s remember the encounters between Dr. Kyle and Dr. Barlaghi. Dr. Kyle being, relatively speaking, a minimalist in terms of therapy, and Dr. Barlaghi being an intensivist. And at that time, since we didn't have great drugs, palliation remained an important component of care for myeloma patients, even though we knew that our standard agents, melphalan, prednisone, VAD, and high-dose dexamethasone, did prolong survival marginally. In the modern era, things really have changed. We have better translational science tools. Serum-free light chains make a huge difference in this field as in other related gammopathies. We have new platforms for clonal genetics, including some of the examples we heard about yesterday in the morning, including things like deep sequencing PCR. And we have new ways to assess organ damage with biomarkers that are available to us routinely in our practice, and that if we use systematically, we can track the trends for patients. We also have a much more circumspect clinical philosophy. We do believe that myeloma now is incurable, but quite treatable, and we owe Dr. Anderson a debt in that regard. We do know that high-dose melphalan is safe. We're not subjecting patients to a high-risk procedure. The mortality at most centers is less than 1%. And we do have effective, less toxic drugs that do need to be developed for patients with high-risk smoldering disease. We're all aware of that. We're struggling to move forward in that area. In addition, patient involvement and advocacy has risen to the top in many countries where advocacy groups have developed and patients are in touch with each other, as I'll show. We also have a changing view of risk in the patients and among ourselves as physicians. This is a blog that was posted by a patient earlier this year. I would welcome the community's thoughts on early treatment of high-risk smoldering multiple myeloma. Parenthesis, high risk for progression to active disease. A patient, very sophisticated patient, really knows his stuff. I'm aware of early clinical trial intervention studies, and then lists areas where the trials are available. Have any smolderers considered this and actually participated in these trials? And then he asks a very sophisticated question. He asks, has anyone who is being treated for active myeloma now, as they think back, would they have been willing to have participated in a trial for high-risk disease had they been told they were high risk? Within an hour, he had 20 opinions, and this is one of them, 20 responses. Hi, I'm in the NIH trial. I went to the NIH and had all the testing done planning to enter the natural history study. My testing showed that I was a high-risk smolderer. Dr. Landgren felt that I had a 75% chance of converting to active myeloma in the next 2 years. And then he speaks about Dr. Landgren's trial, the CRD trial. And he says they are having great results thus far, goes on to describe in a kind of an advisory fashion what he thinks the patient should do, and says, good luck with your evaluation and decision. It's a very different world. And as you can tell from that exchange, and in your clinical practice, we do use this kind of a structural model of thought as we deal with this area. We follow patients closely. We don't want to really wait until they're sick to offer them therapy. We want to be able to preemptively treat them so they don't get sick. So we follow the M protein and other things. And we know that there are aspects of the clone that can influence organ damage, such as light chain nephropathy. And we also know that organs can be at risk, but patients can be asymptomatic. We know there's that gray bar there when patients are pre-symptomatic. And ideally, we'd like to treat patients in that gray zone before they become sick. We follow not only the hemoglobin and the creatinine and the urinary protein, calcium obviously, and bone lesions with a variety of tools, but there are other triggers for us. If a patient has recurrent infections and has hypogammaglobulinemia, it's likely that most of us would treat that patient. If the patient has painful extramedullary disease, the patient would then have myeloma and would move right on to treatment. If the patient had paraprotein-related neuropathy, the patient would move on to treatment. So it's not just CRAB criteria. We're quite sophisticated in connecting the monoclonal paraproteinemia with organ damage in the patient. We do have models, and these are the models that we're using today to try and organize new therapies for smolderers. They're conditional or if-then models. They're based on time to event data, and they attempt to identify risk strata, as Dr. Alexanian did for us as we evaluate patients in the clinic. Unfortunately, we don't have predictive tests. We don't have a test we can apply to a patient at a given point in time and say, yes, you need to be treated now. No, you don't need to be treated now. So progression is a term which largely applies to organ damage at this time, associated usually with increased cell mass and possibly with genetic events, although that data is still quite unclear. One model that we all are familiar with is the Mayo Clinic model as revised with free light chain data. Those variables in the lower left-hand corner are variables that are used to define the risk strata. When patients are in the upper two groups, they have an over 50% chance of progressing to symptomatic myeloma within 5 years. But note what happens to the curves, particularly in the top group. After 5 years, it flattens out. The risk of progression becomes lower if you've had smoldering myeloma for a longer time. The PETHEMA group has also developed a risk profile for us that is very helpful based on two variables, bone marrow plasma cells based on a flow cytometry assay, and immunopoiesis, suppression of non-involved immunoglobulins. And what you can see, if both variables are present in that upper curve, the median time to progression to myeloma is 23 months. And there are two groups that are at much higher risk than the group that scores 0, obviously. So what I think is going to happen over the coming 5-year period is that we're going to move that bar between smoldering disease and symptomatic disease to the left. We are going to capture some high-risk patients as in a redefinition of myeloma requiring treatment. That hasn't happened yet, but it's underway. Because waiting for CRAB events probably doesn't make a lot of sense for our patients, and as you can see from the bloggers, the patients themselves are somewhat impatient. One of the most important contributions to this whole area is the CUI-RE-DEX trial that was conducted by the Spanish myeloma group. It was a very straightforward study in which patients who were smolderers were randomized to either Lendex or observation. And they had to be high-risk smolderers. And high risk was defined by a combination of Mayo and PETHEMA criteria. The results of the trial are stunning. It's not a perfect study, and we can talk about that, but the results are stunning. In the observation arm, there were 60% of patients who were progressors to symptomatic myeloma, many with bone disease and some with renal disease. That contrasted sharply with those in the Lendex group. And stunningly, there was a difference in overall survival. In the initial presentation, that difference was 93% versus 76%. And in the New England Journal publication, the difference was 93% versus 80%. 20% of the smolderers died within a 3-year period, a stunning number. So looking more in a more focused way at the study, eligibility criteria are as listed here. You had to have smoldering disease diagnosed within the past 5 years. So you had to be a high-risk smolderer diagnosed within the past 5 years. There was a stratification element. Serum free light chains were not used. Benz-Jones protein was measured apparently with each cycle of therapy or each visit. And bone imaging was not as sophisticated as we would routinely use in our practice. A skeletal survey was performed at baseline, repeated only with symptoms, and MRI was not routinely used. So these are limitations of the study, but all patients were asymptomatic. And when you look at the absolute risk reductions, the numbers are really quite stunning, as I've said. And when you look at the number needed to treat, you need to treat 2 patients to prevent 1 progression. You need to treat 7 patients to prevent 1 death. We currently treat 20 patients with DVT and PE with anticoagulation to prevent 1 death. We currently give patients, after they've had an MI, high-dose statins So we treat 15 MI patients to prevent 1 death. So these numbers are well within the range of modern medical practice. The guidelines, however, of the working group published in 2010 continue to state that patients with high-risk disease should be considered for clinical trials, and that the standard remains observation, expectant observation. And there are numerous clinical trials available. But if you look at each of the trials, what you'll see is that the definition of high-risk smoldering is a little different from trial to trial. And an important variable, I think, is the time from diagnosis. So you have to look at that too when you're considering referring one of your patients for these studies. The pharmaceutical companies are willing to spend many millions of dollars to make hundreds of millions, if not billions of dollars in the future. And our patients are actually the grateful beneficiaries of this. And I think it's to the credit of pharma to have picked up this disease in this fashion, frankly, even though it may indeed impose further strains on the healthcare system and on us in our practices. So we had the case that we presented initially. We have a new patient now who walks in, picked up because total protein had been elevated. She's got an M spike greater than 3 grams. She's got 190 milligrams of Benz-Jones protein. Her free light chain ratio is skewed. She's got standard risk cytogenetics in fish, no evidence of organ damage. NTX creatinine ratio, a marker of bone turnover, is appropriate for postmenopausal woman. So this case is the sort of case that we might see and consider for a study. But we know that her spinal MRI is negative. And based on work that Dr. Hillengass has done, patients who have less than 1 lesion in whole body MRI have a much slower time to progression from the smoldering state than those who have 1 or more lesions. So the spinal MRI may be helpful in her case in guiding our thinking about her and our direction to her. We also know that the NTX creatinine ratio, based on work that Dr. Chirpos and Dr. Berenson have done, can be predictive of risk of death as well as risk of skeletal related events in patients receiving conventional chemotherapy. This work is somewhat old, but it's also useful to note that this is another way to look at the patient's risk of bone disease. And also a justification for using bisphosphonates in a judicious fashion in patients such as this. We have some tests for progression and response. We follow them. We look for trends. And I would urge folks who are caring for smolderers to use imaging studies judiciously, perhaps an annual MRI of the spine and pelvis, if indeed some abnormality has been seen. And if there's evidence of progression, many of us use annual skeletal surveys. If there's evidence of progression, then we have to seriously consider offering therapy. What about cytogenetics in fish? Are they useful? The answer there is probably not. The Spanish looked at this very, very thoroughly, and they did fish on almost all of the samples they obtained on patients. And there was no group of abnormality or grouping of abnormalities that predicted progression of disease. They had 11 samples pre and post progression. 4 of those samples were normal at both times of testing. There were 2 samples that progressed to high-risk features, deletion 17p and gain 1q. And those samples may be associated with the kind of accelerated increase in M protein, perhaps, that Dr. Alexanian described many years ago. It's not discussed in the article. They do have gene expression profiling data that's suggestive, but needs to be validated, and perhaps there will be a signature for progression. We can't really be sure at this point. I'm going to discuss a couple of trials and close. So there are 2 trials that I want to highlight. One is the ECOG trial for high-risk smolderers within 12 months of diagnosis, negative skeletal survey. It uses serum free light chains. Gene expression profiling is one of the correlative endpoints. MRI, spine, and pelvis, one of the correlative studies. It's a well-designed trial, large numbers, 330 patients, 160 in each arm, and we expect it to accrue in 4 years. A very important trial, in part because of what we'll learn based on the correlative studies. And the second trial is the CRD trial at NIH. It's a pilot study. It allows stem cell harvest. It's carfilzomib, Revlimid, dexamethasone for high-risk disease. Many correlative studies. You can find Dr. Landgren's Kyoto presentation at this website. And one point that Dr. Landgren makes that I think is very important is about the patients who've come to be treated and the studies that he's done, the PET CTs and the CTs, unmasking actual bone damage. And not unlike the patient in the blog who went to NIH planning to enter the natural history study and was told he had high-risk disease. There are patients going to NIH as smolderers and being told they have myeloma. And when you look at these two studies, what you see is the perplexity of the current era when you might be dubbed a smolderer for the ECOG trial and might learn that you actually have active disease at NIH. So hopefully this situation will be clarified over the next couple of years, and I expect it will be. So I don't routinely treat newly diagnosed patients with no evidence of evolving organ damage. I do vaccinate them. I observe them closely. I will offer them clinical trials. I follow clonal proliferation, as all of you do, and I follow for trends in organ damage with respect to the major organs. And not all high-risk patients should be treated immediately as a standard of care. You have to determine what the patient wants. If the patient can't live with the risk of symptomatic myeloma, then certainly refer to a study. There are plenty of phase 1 and phase 2 trials. If the patient is not sanguine with the idea of entering a phase 3 trial, use the best metrics for clonal disease and for organ damage, image appropriately as well. And finally, this is a changing landscape. The working group is going to have very clear recommendations about how the line needs to be moved to the left. And we're all very sensitive to the rationality of our definitions, to the possible need for radical change, particularly with respect of redefining myeloma needing treatment, and perhaps with regrouping the category of plasma cell diseases so that we take into account risk from the clone on the one hand and risk from organ damage. And finally, in closing, we can't overlook the fact that the major driver for advances in new drugs and the like is actually relapse refractory disease. And what I've said applies only to these early cases. Thank you.